Hello, my name is Christian. Thank you for letting me present some work we have done looking at Penthrox and its use as an adjunct for orthopaedic procedures during the COVID-19 pandemic. Methoxyflurane was an anaesthetic agent used in high concentration for GA-like effects in the 60s. However, concerns were raised after high dose-related nephrotoxicity in the 70s. Since then, it has been reintroduced as a low-dose analgesic device called Penthrox. This is carried by paramedics and life-saving crews in countries such as Australia. Only recently in Europe in 2015 was the evidence reviewed allowing Penthrox to be used again. Penthrox is a handheld device with simple patient instructions that has good evidence behind its analgesic effects. There is minimal evidence behind its use in orthopaedic procedures. Penthrox can be used with minimal support and monitoring when compared to deeper sedative agents such as propofol. During COVID, part of the Cornwall response included moving the orthopaedic services to the elective centre and running an orthopaedic MIU. We had limitations of our airway-trained staff and ability to monitor patients. Penthrox was a good solution to this. We describe our experience using Penthrox to manage common orthopaedic procedures in a minor's ED setting. We focus on its effectiveness and whether it enables quicker patient management, which is pertinent in the COVID-19 crisis and also in pressurised ED attendances. We retrospectively analysed all usage of Penthrox in a 2-month period. Patients were identified from the CD book and data fleshed out from electronic records. All procedures were reviewed by 2 independent trainees. Success was recorded as manipulation of fracture to a safe position or joint relocation. Radiographs were used to confirm timings. Mean age was 57.1 with a range of 17 to 91. 24 males and 63 females were treated. This slide shows the majority of procedures performed under Penthrox were by orthopaedic registrars. This diagram summarises our Penthrox usage. 54 fractures were treated, 31 dislocated joints managed and 12 miscellaneous procedures performed. Of the 54 fractures managed with Penthrox, 1 fracture required 2 doses. The most common fracture was that of a distal radius. Success was 100%. Mean time to satisfactory radiograph in fracture was 79 minutes and discharge 4 hours. The quickest time was 17 minutes and 41 minutes respectively, highlighting the speed that Penthrox enables. Dislocations were managed with varying success with Penthrox. Native elbows were reduced most successfully in 4 of 4 occasions. Native shoulders were reduced in 65% of occasions, and prosthetic hip dislocations were reduced under Penthrox in 3 of 10 situations. We show that where Penthrox was a successful adjunct to reduce a joint, patients had a quicker discharge. This can be confounded by the least successful procedure, total hip replacement relocation, likely to have the highest physiotherapy requirement. Penthrox was also used for applying humeral braces, reviewing wounds and removing external fixators. Limitations. We did not record any PROMS data. This is being answered by a separate national study. We didn't compare it to alternatives such as Entonox. Comparison was only made to theatre. Penthrox was being used by orthopaedic trainees. While we may be better at manipulating fractures, we may be less good at giving and supervising sedative agents. Going forward, Penthrox will continue to be used in ED. We will collect more data on it, including PROMS. Penthrox has already been compared to Entonox for pain relief, but not for procedural benefit. One may be superior. Penthrox use can be protocolized to highlight where it can be effective and where alternatives should be sought. For example, we have sought strong alternatives for hip dislocation management outside COVID times. Thank you. Any questions?